You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 5th, 2021. This week, COVID in the heart, percutaneous valve repair, AF screening, and a comment on social media. First, the good news on COVID continues. Cases plateaued for a bit and now are decreasing further. I read a tweet that in Connecticut, my birth state, 1 in 5 people have received at least one shot. It's pretty good. Another underappreciated thing I learned this week is about the massive reduction in severe COVID after vaccination. Dr. Monica Gandhi, an IT professor at the UCSF, tweeted out a table of the Phase 3 placebo-controlled vaccine trials. I'll link to that tweet and table. The key finding is that nearly 100,000 people have actually received the vaccine. Of these, guess how many COVID cases there were significant enough to be admitted to the hospital? 1. Yes, 1 in 100,000. That is amazing. I think soon the pandemic will be over. Next topic is COVID in the heart. Again, I will keep this brief, but a prominent group of sports cardiologists have published yet another study looking at cardiac effects post-COVID. The first author is Matthew Martinez, and JAMA Cardiology published a cross-sectional study of nearly 800 professional athletes who underwent return-to-play screening after testing positive for COVID-19. These athletes were from the big leagues, like Major League Soccer, Major League Baseball, NFL, NHL, and men's and women's NBA. 58% had some symptoms, 42% essentially no symptoms. Only one of these patients was admitted for short observation, then discharged. Testing was performed through the team, so this was a bit of a pragmatic real-world survey study. 30 athletes, or 3.8%, had some abnormal finding on basic screening. 15 by echo, 6 by ECG, 5 by troponin, and a handful had multiple abnormalities. After consultation and review of the data, 30 of these patients had CMR. 5 athletes, or 0.6% of the entire cohort, had some evidence of inflammation on the scans. 3 with findings consistent with myocarditis and 2 pericarditis. All 5 of these CMR-positive cases came from athletes that had symptoms. In other words, no asymptomatic athlete had a positive finding on CMR. Now, the limitations of this study were pretty significant. CMR was not performed in the vast majority, so you can't know the true incidence of abnormalities. And there was no core lab. It's hard to sort out really abnormal findings. For instance, the authors cite previous data showing that low normal EFs by echo are not an uncommon finding in elite athletes. But many of the abnormal transthoracic echoes in this survey were for mildly reduced EF. Or was it COVID, or was it just the athlete's baseline? By the way, I see this issue often in the office. My solution is to have the athlete do a little exercise, then get back on the echo table and the EF is normal. We also know the difficulty of interpreting ECGs in elite athletes. There was also significant variation in the time to testing. Some athletes may have recovered by the time of testing. But this is still pretty strong, reassuring, optimistic, real-world data. A few take-homes. Young athletes do very well with COVID-19. 800 cases and no severe COVID-19. I'll use the author's own words, quote, "We observed only rare cases of athletes having potential cardiac involvement." The other take-home is that the ECG underperformed. The notion of adding a routine ECG in athletes is fraught. I see this problem often as well. Normative findings in athletes are not well recognized by most cardiologists. I think it also underscores the use of CMR should only be used as a downstream test after careful consideration on a case-by-case basis and not for screening. And finally, this study, like all other post-COVID cardiac studies, lacks a comparator group. What would we find if we did similar testing after febrile illnesses that were due to non-COVID respiratory viruses? My hunch is that it would look similar. Okay, next topic, clipping mitral and tricuspid valves. A group at the University of Cologne, first author Maria Korber, published a research letter in JACC Intervention on post-op delirium after percutaneous repair of the mitral and tricuspid valves. Now, this is a small study, but an important one. Here's why. When you read big trials in cardiology, you're getting data from a highly selected group of patients. Nearly all trials, especially those sponsored by industry, are enriched with patients most likely to benefit. This is not nefarious. It is a way to identify a group that can benefit from the intervention. I think the best example, is that most cardiology trials exclude patients with severe kidney disease. They do this because bad kidneys represent a strong competing cause of bad outcomes, such as death. Another example of how important patient selection is look at the difference between the MITRA-FR and COAPT trials of the MitraClip device. In MITRA-FR, there was no benefit. In COAPT, the benefit was huge. And when you look at the table 1 of these trials, that is the patient characteristics, it's sort of hard to tell a difference. But the proponents of the MitraClip say there were differences in the size of the LV relative to the severity of the MR. But these are determined by ultrasound shadows, and they're measured in millimeters. Now, my point is not to re-argue the two divergent trials. It's only to point out the crucial nature of patient selection in using advanced technology, especially in older patients. This, I believe, is the core challenge in clinical cardiology. Most patients we intervene on in the real world, outside of trials, are much sicker than those in the trials. Now, mitral and tricuspid disease that is considered for percutaneous repair is by definition a disease of the aged and infirmed. Otherwise, they would have had open surgical repair. And brain disease is a common comorbid condition in older patients. Post-op delirium is an under-recognized severe complication of any intervention. This German team studied 177 patients at their center who had mitral or tricuspid intervention. Now, they systematically studied delirium using an accepted scoring system called the CAM-ICU score. Post-op delirium occurred in 9%, nearly 1 in 10 patients, and no baseline characteristics predominated in those with or without post-op delirium. The procedure was just as technically successful in those with or without delirium. Hospital stays were longer in patients who had delirium, and those who had delirium had a much higher rate of death at 6 months. The point estimate of the hazard ratio for death was 3.84, so nearly 4x higher rate of death. And the confidence intervals range from a 41% higher rate of death to a tenfold increase. I laud the authors and the journal for publishing this data. Patrice Wendling has great news coverage of it. She quotes Dr. David Wood from the University of British Columbia, who said delirium was an important thing to study and emphasized the notion that iterations of the procedure to more minimally invasive will likely decrease the incidence of delirium. And I agree that moving away from 4-hour procedures under general anesthesia will improve things. But I also think cardiologists must always remember that mitral regurg and tricuspid regurg are often just one of the many causes of morbidity in older people. Our challenge is not whether we can clip a valve, but whether we ought to. Studies like this remind us of this core challenge. Next topic, AF screening. Whenever I hear about a randomized controlled trial in the screening space, I get excited. The name of this trial is SCREEN-AF. It's led by Canadian investigators. First author David Gladstone and JAMA published a paper. SCREEN-AF studied the question of whether screening for AFib with a 2-week patch ECG electrode placed twice at 3-month intervals would be better than routine care, or basically no screening. Now, smartly, the investigators enrolled patients over the age of 75 who also had hypertension. Thus, they gave themselves a good shot at finding AFib, as age and hypertension are two of the many associated conditions of AFib. The primary endpoint of the study was detected AFib. The secondary endpoint was prescriptions for oral anticoagulation. And within the active screening arm was a sub-study comparing the patch electrode to a twice-daily blood pressure and heart rate recording from a blood pressure machine capable of indicating an irregular pulse. Now to the results. 856 patients were enrolled from 48 primary care practices. The mean age was 80 and a CHA2DS2-VASc score 4, so these were definitely higher risk patients. AFib was detected in 23 patients, or 5.3% of the screen group, versus 0.5% of the routine care group. Now, obviously, an odds ratio of 11 is statistically significant. The absolute risk difference is 4.8%, or a number needed to screen of 21. I'll come back to that. Of those with AF detected, the median time in AF was about 6 hours, and median duration of the AF is 5.7 hours. Only 3 patients of more than 400 screened with this patch had more than 24 hours of AFib. Oral anticoagulation was started in 15 of 20 patients with patch-detected AFib. Now, in the sub-study comparing the patch screening to just twice-daily blood pressure heart rate measures, found that the blood pressure and heart rate device was clearly inferior, with a sensitivity or true positive rate of 35% and a specificity or true negative rate of 81%. Now, here's the chance to diverge a little into Bayes' theorem. The prior here is the 5% prevalence of AFib in the screen group. The likelihood ratio, or Bayes factor, is the sensitivity divided by the 1 minus the specificity, or the true positive over the false positives. Here, 35% divided by 19% is 1.8. This is how much the blood pressure and heart rate test would update your chances of having AFib if it was positive. Thus, the posterior probability of having AFib after a positive blood pressure and heart rate test is the prevalence of AFib, 0.055%, times the likelihood ratio, 1.8, is equal to 9%. This is a terrible test. In this study, the incidence of AFib was 5%, but if you had a positive irregular heart rate signal on the blood pressure cuff, it only went up to 9%. All right, comments on the trial. This appears to be a well-conducted trial, and it is in line with every AFib screening study that I have reviewed. That is, if you look for AFib with any device, you will find more AFib, and this will lead to more treatments for oral anticoagulants. But of course, that is not the endpoint we care about. We care about making people live longer or feel better. That means reducing stroke or death. This study doesn't come close to knowing that. In fact, there were 2 ischemic strokes, and both were in the screen group. But even if we assume, and it is a very big assumption, that treating patients with short duration, patch-detected AFib lowers the stroke rate, let's do a calculation on how much we would need to screen to reduce stroke. The number needed to screen to pick up 1 case of AFib in this study was 21. If we're generous, the absolute risk reduction for oral anticoagulation in this high-risk group is about 4%, or an NNT of 25. So, the number needed to screen to prevent 1 stroke with expensive medical-grade ECG patches was 21 times 25, or 525. Now, theoretically, and with all the limitations of NNT, so don't get mad at me, this implies that 524 out of 525 patients exposed to this type of screening get no benefit. And this doesn't include the risks of downstream testing from the false positives and other incidental arrhythmias, such as symptomatic Brady or PVCs. nor does it include the risks of increased bleeding from the oral anticoagulation. Now, a word on these monitors, which go under the name of Zio. They are very, very useful as diagnostic devices. This, of course, is different from screening, namely, people who are using them for diagnostic purposes have a problem and have sought our help. People like those in the screening trial were asymptomatic. Now, the authors write about these ECG patches, quote, compared with implanted cardiac monitors, wearable ECG devices are non-invasive, less costly, more accessible, and can be self-applied with patients at home, and they have fewer false positive results. And these are all probably true things, but less costly is relative. If your insurance does not cover these patches, at least here in the US, they are very expensive. And even if they are covered, remember that we all pay for costly, low-value health care in the form of higher premiums. Finally, make no mistake, when the evidence shows that screening for AFib cost-effectively reduces an important outcome like stroke or mortality, I will become a huge advocate, like I am for the COVID vaccines. I don't think we're there yet. Now, brief comment on social media. If you are a doctor and you pay attention to social media, recent news could be considered quite depressing. One of the preeminent journals, JAMA, got into trouble with a podcast about structural racism. A couple of prominent doctors at Oregon Health Sciences University are embroiled in a sexual harassment suit, which will be settled slowly with due process. Of course, I would never dare to comment specifically on either of these issues. What I will say, especially to any young listeners, is that I love this job. Every morning, I get on my bike knowing that in some way I will help people. It may be curative in the EP lab, or it may be through the act of caring in the clinic. I also know that there will be people who I work with who also have the same simple goal, to help people. And when I am not working in the hospital, I spend time trying to better understand medical evidence and Bayes' theorem, which is truly, truly a beautiful thing. If you chose this profession, you did good, and it helps to remember that. So that's it for this week in cardiology. As always, I'm grateful that you listened, and remember, please, it really helps if you take the time to rate and review us. That way other people can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.